This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1126, recorded on June 27th, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I see some viruses on that bow tie, don't I?
You do, and they've got these spikes sticking out all over. I wonder what it could be.
Do you think it's SARS-CoV-2?
Well, it's definitely SARS-CoV. It's hard for me to tell, whether it's the one or the two. Considering this was made prior to 2019, probably the
SARS-CoV-1, right?
Version 1.
I haven't seen that one before. That's a new one.
Yep.
Very good.
All right. Well, not sure how many Kurt Vonnegut fans we have, but perhaps to lighten the mood before we get into things. True terror is to wake up one morning and discover that your high school class is running the country. So Barnaby just graduated. My youngest, my 19-year-old, just graduated from high school. So I'm looking out at his class. Maybe not as terrifying if that class runs the country compared to my high school class, because I was a member of that high school class. So what could be more frightening? Lots going on with RSV. So it was actually my cousin Peter Dates texted me the other morning. Dan, what do you think? Well, we've covered the durability of some of the RSV vaccines. So the GSK's vaccine, Arexvy, about 68% effective over 23.3 months in a clinical trial. Pfizer's Abrysvo was 78% effective after 16.4 months, right? So, really good, holding kind of steady. And then, everyone's, of course, thinking, oh, those mRNA vaccines, those are just going to, knock everyone down. Well, Moderna's mRNA vaccine for RSV showed an efficacy at 3.7 months. So first season, 78.7 or 80.9. And this is when they define it as RSV lower respiratory tract disease with either 2 or more or 3 or more symptoms, but only about a 50% efficacy in preventing the illness after 11 months.
18 months.
18 months. Sorry about that. So 18 months. Yeah.
So the Arexvy and Abrysvo, they're both protein-based vaccines, right?
Mm-hmm. And this is mRNA.
This is very interesting. We're starting to see a picture formulating here, aren't we?
That's what I'm a little bit concerned about, right? Like we all got all excited about mRNA has saved the day. And I'm really kind of curious, and we're going to talk about a study coming up where, it looks like with the mRNA vaccines, you got to get a booster every single year. It doesn't seem like you get the durability that we were used to with our traditional vaccines. Is it an issue with the mRNA technology and how that triggers the immune system? I'm kind of curious, right? Novavax, right?
Yeah. So what's the durability of Novavax? Do we have any studies on that?
I would love to see those. I was kind of looking for those, and if I can dig some up or get some data, I'm going to talk a little bit. But that is a very interesting thing to be thinking about.
Just anecdotal information. When I was at the Karolinska a few weeks ago, one of the immunologists, she said protein is going to be more durable overall than mRNA.
Let's hope Novavax as a company survives and we can find out.
Yeah, right.
So I don't know if you remember last year, right? I was trying to get my Novavax vaccine before one of those conferences, and I ended up getting an mRNA vaccine. It was just the timing issue.
Yeah.
Still ended up with COVID. I got an mRNA vaccine. Who knows? But we'll see. All right. We also got news as of Wednesday, the 26th. The CDC updates RSV vaccination recommendation for adults. CDC updated its recommendations for the use of respiratory syncytial virus vaccines, RSV vaccines, in people ages 60 and older. And it's sort of interesting. The New York Times headline, right? They sort of pull back. They're actually recommending less broad. So everyone aged 75 and older should receive the RSV vaccine. People ages 60 to 74 previously this was just go ahead, share decision making. They say people ages 60 to 74 who are at increased risk of severe RSV, meaning they have certain chronic medical conditions such as lung or heart disease, or they live in nursing homes, receive the RSV vaccine. And this recommendation is for adults who did not get an RSV vaccine last year, right? Because last year, people got those 2 non-mRNA, right? We still think there's durability there. So the RSV vaccine is not currently an annual vaccine. Who knows? For the mRNA, maybe it needs to be. So people currently do not need to get a dose every RSV season. Now, eligible adults can get an RSV vaccine at any time, but people who've been listening might think about this and follow the CDC that says, or the CDC Advisory Committee says the best time to get vaccinated is probably late summer, early fall, because that's about when RSV usually starts to spread in communities. And remember, it starts a little earlier down in the Florida, down in the South, so those are probably late summer. Here in the Northeast, we get a little bit later. So now Mandy Cohen, what does she have to say? The CDC has updated its RSV vaccination recommendations for older adults to prioritize those at highest risk for serious illness from RSV. And then just reiterates people 75 and older, 60 to 74 with certain chronic medical conditions or living in a nursing home should get 1 dose of the RSV vaccine to provide an extra layer of protection. So what's going on here? Why did they kind of step back a little? So a couple things. So one is the suggestion that the committee viewed the potential elevated risk of the neuroinflammatory condition Guillain-Barré syndrome as a reason for hesitation, despite evidence suggesting that GSK's Arexvy does not statistically increase the risk. The signal's all coming from Pfizer's Abrysvo. The other point is that the advisory group acknowledged that this whole concept of shared decision making, it's really just not easy to do in clinical practice, and you end up with this unclear messaging regarding who really should be vaccinated. So I think the sort of acknowledgement that patients and their providers could use a recommendation, not just you guys sort it out, shared decision making. Now, the group also postponed a recommendation for use of GSK's Arexvy in people ages 50 to 59 due to a lack of data, and again, this Guillain-Barré sort of lingering concerns.
But as you just pointed out above, the durability of a single shot is very good, so this is okay.
Yeah, it's great. Well, it looks like it's great for the traditional GSK Pfizer RSV vaccines. Maybe not so good with the mRNA. Now, of course, this was not head to head. Maybe there was something special about the mRNA vaccine trial. I have to tell you, if it went the other way, they wouldn't be throwing any caveats. They'd be just, Anyway. All right. Now, this is really disturbing, moving into COVID. So I put up the map, and there's a link. So I'm sort of recommending everyone click on this link and look at our map. What is going on in Puerto Rico? It went from, this sort of hashtagged, like a teal color to green to yellow. Now we're up at orange. We're up at 6 to 8% of deaths in Puerto Rico are due to COVID. That's a lot. So we're really seeing a rise there, and that's a hard endpoint. And we're basically seeing for the wastewater that pattern that we saw last year before. We see this summer rise, and then a little bit of a drop, and then the winter peak. We're seeing that summer rise. We'll see what happens there. I have to say locally, we're starting to see admissions. Really kind of a downer this week. I had a 33-year-old gentleman die from COVID in the ICU. And we're seeing admissions. We're seeing people end up in the ICU. And maybe we'll talk a little bit upcoming, like what is going on? Why are we losing ground here?
So Puerto Rico is a vacation destination, so that could be part of it.
Interesting. Okay. All right, so here's I wanted to discuss what I thought was a really interesting article. This is, there's every so often, hopefully an episode, Vincent, where they're going to have a little sound bite because we're teaching something important. Doesn't happen very often, but I had dinner, right, with the whole ID group at Columbia, and Magda, the head of the division, was talking about how I am valued for the wisdom that I bring to the group. So I was a little embarrassed, but maybe this is some of that wisdom, Vincent. But it's really borrowed wisdom, right? So this is the article, Human SARS-CoV-2 Challenge Uncovers Local and Systemic Response Dynamics, published in Nature. So I suspect most of our listeners remember when the Brits exposed a bunch of healthy people to pre-alpha SARS-CoV-2 to see what would happen. A bunch of crazy scientists over there. So here the investigators report on results from single-cell multi-omic profiling of nasopharyngeal swabs and blood, looking at, we're going to go more into depth, these abortive, transient, and sustained infections in seronegative individuals challenged with SARS-CoV-2. So first off, I want to sort of walk slowly through what I think is really important language. So the first concept, the first term is abortive infection. So as we're going to learn in this article, some people get exposed to the pathogen, they remain PCR negative, they remain seronegative, they're asymptomatic, but they have a detectable innate immune response. Okay, so that's abortive infection. Transient infection, you get a positive PCR, but not more than one quantifiable detection of viral RNA over time. So you can pick it up, there seems to be some replication going on, high enough to be detected, and then that's the end of it. And then this is like what we usually talk about, sustained infection. At least 2 quantifiable detections of viral RNA over time. And so you can see that this is different from asymptomatic versus symptomatic, and perhaps opens a discussion about what is going on with those abortive infections that seems ideal. So would we even call it an abortive infection versus an abortive exposure? I think as we learn here, there must be some degree of limited viral replication and limited infection, as we're seeing an immune response, not just an adaptive response. So this is a complex 38-page Nature research article that deserves a few hours of time. So there is a brief discussion, and this is a brief discussion. I do encourage a deeper dive, just the brief discussion. So the investigators report detecting activation of MAIT cells and certain monocyte responses that occur during early and abortive infections. So MAIT cells, who's heard of those? These are mucosal associated invariant T cells, so MAIT cells. And they're a subset of T cells that you can find in the blood, but they're also enriched in many tissues. So the MAIT cells, MAIT cells, express a semi-invariant T cell receptor restricted by the MHC class I related MR1 molecule. During sustained infections that lead to disease, symptomatic COVID-19, they observed an immediate and new APR in ciliated cells at the site of infection. In addition, they described a distinct cell state for activated conventional T cells that harbor SARS-CoV-2 specific T cell receptors, and showed that this signature can be projected onto patient cohort data to identify disease-specific T cell responses. Now, in sustained infections, they saw global activation of interferon signaling that affected all circulating immune cells. Now, interesting in that the activation of interferon signaling in blood preceded widespread activation at the site of inoculation. Sort of odd, right? We're seeing this widespread before we see a lot going on locally. Now, the activation of interferon signaling at days 5 to 7 after inoculation coincided with global immune infiltration and a peak of detectable virally infected cells. This relatively slow immune infiltration at the site of inoculation is in contrast to the immediate immune infiltration that we observed in individuals that were only transiently detectable. And this data suggests that individuals with HLA-DQ-A2, so this is MHC class II expression, seem to be better at preventing the onset of this sustained viral infection. So very, very complicated stuff here. I don't expect everyone to take this all in, but really the takeaway I wanted was this concept of abortive infection, transient infection, and then sustained infection that might be symptomatic or asymptomatic. Okay. All right. Now, This is fun, Vincent. Remember when we discussed that study where it appeared that coffee can inhibit multiple variants of SARS-CoV-2 infection by restraining the binding of the SARS-CoV-2 spike protein to ACE2 and reducing TMPRSS2 and cathepsin L activity? And they suggested that we should all be drinking and perhaps inhaling a little bit of coffee each day.
Right.
You were the one who suggested that we needed to be actually aspirating or inhaling those 2 cups, not just drinking them down. Well, this week, more fun or less fun, cannabis, tobacco use, and COVID-19 outcomes, where they tell us that smoking on the weed may not be the best idea. This is a JAMA publication. In this study of over 72,000 patients, they reported that current tobacco smoking was significantly associated with increased risk of hospitalization, so odds ratio 1.7, ICU admission 1.2, all-cause mortality 1.37. But what about smoking on the weed, cannabis use? Also significantly associated with increased risk of hospitalization, almost doubling it, odds ratio 1.8, ICU admission 1.27, but not all-cause mortality. So they did adjust for a number of factors, including vaccination, comorbidity, diagnosis state, demographics. But apparently, Vincent, you can inhale your coffee, but don't inhale the cannabis.
You know, cannabis, tobacco, they are plants. You burn it, you inhale the smoke. There's just no way this is going to be good for you. Didn't someone say at one point a while ago that weed was good for COVID?
Oh, yeah. No, I think I won't mention which family member, but if my family's listening, they know who we're talking about. He was smoking weed to keep himself. He was like, oh, don't you worry, Dan. I'm not going to get the COVID because I'm surrounding myself in a cloud of the weed smoke. I'm like, what are you doing? His wife was quite unhappy with his approach. And here's some science saying his smoking on the weed is not a good idea. He ended up with COVID. And then when he called, I'm like, oh, that must have been a mistake because you're smoking on the weed. Doesn't that protect you? All right. Now, this is an interesting article. The article estimated effectiveness of the BNT162b2-XBB vaccine against COVID-19, published in JAMA Internal Medicine. Now, these are the results of a test-negative, case-control study performed to estimate the effectiveness of the BNT162b2-XBB vaccine against COVID-19 associated hospitalization and emergency department or urgent care encounters among adults in the Kaiser Permanente Southern California health system between October 10, 2023 and December 10, 2023. Cases were those presenting with an acute respiratory illness, and then you have, your cases had a positive PCR for SARS-CoV-2, and then the controls had the acute respiratory illness, but they tested negative. So among 2,854 cases, 15,345 controls, you end up with this median of 34 days prior versus not having received the XBB vaccine of any kind, 62% against COVID-19 hospitalization, 58% for ED urgent care visits. Now, this is the caveat that I want to point out. Compared with being unvaccinated, those who had received older versions of the COVID-19 vaccines, right? They said, oh, I've been getting enough of them shots. I'm done with that. I don't need a shot of that XBB this last fall. They did not get their yearly shot as recommended, did not show statistically significant reduced risk of COVID-19 outcomes, including hospital admission. So seemed to be no durability past that year, right? So
I think that's the key. It's not really a strain-specific issue. It's durability.
Yeah.
Because I think T cells should be, we've seen a number of studies where T cells help moderate disease severity, but I think they're just not lasting here because of the mRNA vaccination.
Yeah, I think this is the theme that I'm concerned about. The mRNAs, you make them quick, they're great, you get them out of the gate, you protect people, but then now you've got some time. Do you just keep giving an mRNA vaccine every single year? And we see that people just really are not up for that. Or once you've sort of got a little bit of time, do we move over to a protein-based, what people still refer to as the traditional platform approach? We're starting to see that story, and we'll see. Like, is this an mRNA vaccine thing? Is it a COVID thing? Well, with the RSV data, it's starting to suggest it might be an mRNA vaccine thing.
Yeah, I think we need to have some studies to confirm that with the protein-based vaccines. Yep.
Yep. All right. Early viral phase. You test positive. Unfortunately, we're getting a bunch of these folks now as we're seeing numbers come up. We have guidelines. We have NIH COVID-19 treatment guidelines. We'll leave a link. We have ID Society of America, IDSA guidelines. We'll leave some links. And we'll leave in that COVID-19 drug interaction checker. Like I still get people texting me, calling me like, hey, what about this interaction? Go to covid19-druginteractions.org/checker. Look them up. They're great. They guide you. They let you know exactly what to do. So keep checking those interactions. It's not hard to do. You just need a computer and access to the internet. Maybe your phone, which is really a computer in your pocket. All right. This week, I will mention the article, Adjunctive Statin Therapy in Patients with COVID-19, a systematic review and meta-analysis of randomized controlled trials published in the American Journal of Medicine. So this is, make sure you kind of go a little bit into this. Don't just read the headlines. I read the headline. I was like, wow, that's surprising. And then I read the article. So here the authors systematically searched Medline, Embrace, Cochrane, and clinicaltrials.gov databases from March 2020 to late April 2024 for randomized controlled trials, RCTs, comparing statin versus no statin use in patients hospitalized with COVID-19. What about the dark and the gray web, Vincent? Right? I love when they do that. Well, they pooled risk ratios and hazard ratios, applied this random effects model, and they ended up with 7 RCTs, 4,262 patients, of whom 2,645, or 62%, were randomized to get a statin. Now, they do point out that although individual studies included in this meta-analysis have not found any statistically significant difference in overall death, when they piled the cow pies 7 high, they turned into gold. And they reported that perform this meta-analysis, compare with no statin, statin use significantly reduced case fatality rate. Give us a relative risk of 0.88. And you can see the confidence interval, 0.80-0.98, like they just make it. So maybe a 12% reduction. There are, however, no statistically significant differences between the two groups in length of hospital stay, elevation of liver enzymes, C-reactive protein levels. A bit less impressive when you actually look at the figures. So if you look at figure 2, I'm going to say, like, before you start quoting this, go ahead, look at figure 2. This is really a study of remap cap that has a weight of 63.1% and is really just getting pushed over the line by adding these other studies. And even closer inspection, you see that they're really only adding 4 studies, as the Davudi and the Resist study contribute a weight of 0% each. And then the Ghaffori and Hajazi, really, they're contributing 0.4% each. So unfortunately, this is behind a paywall. It's going to be hard for you to see more than the headline, but not sure how many people will get a chance to move past the headline, see these actual forest plots.
So Daniel, is 12% worth doing?
If it was true, right? If it was true, then, but the only problem is I don't know if it's true, right? Mm-hmm. When you have to sort of like do all this, to make it true, right? The REM cap, which is 1,835 statin folks, you have 504 events, not reaching statistical significance, maybe a little bit of a trend. And now you're introducing a new drug, statin. So, yeah. I'd love to get a 20%. You start of adding up all we can get, but you want to know if it's really true. And don't forget all the negative data, all the studies that there's always a bias towards positive data. So when it's this hard to build the story from what's published, it makes me worry. All right, Paxlovid, right? Another article, nirmatrelvir and ritonavir for inpatients with severe or critical COVID-19 beyond 5 days of symptom onset, right? A propensity score-matched multi-center retrospective cohort study published in BMC Infectious Diseases. For this study, a prospective score-matched cohort was constructed by using multi-center data from 6,695 adult inpatients with COVID-19. So these are inpatients, more than 5 days have gone by. We're in China, December 2022 to February 2023. This is after the epidemic control measures were lifted. The symptom onset of 1,870 enrolled severe or critical inpatients was beyond 5 days, and then they either end up getting Paxlovid plus standard treatment or just standard treatment, no Paxlovid. In the Paxlovid group on day 7, the number of patients with an improve in the SOFA, that's a sequential organ failure assessment score, was greater than equal to 2, was much greater than in the standard treatment group. And you're not seeing any impact on glomerular filtration rates or kidney function. So they're doing better looking at their SOFA score. Additionally, the rate of new intubation was lower, the p-value of 0.004. Basically, the clinical benefits we're seeing here, even when you were missing those first 5 days, even when they're in hospital. But this is really preliminary, and the authors point this out, that we need some more randomized controlled trials to really validate, when does that window close? All right, and number 2, we do have remdesivir, right? This is sort of going into week 2, the article above. So we also have to ask the question, is this any better than remdesivir? Why don't we just put people on remdesivir where we do have the data? Okay, number 3, molnupiravir, convalescent plasma in some situations. And remember the isolation guidance. You're still contagious. You could still give it to other people. I think people seem to forget this as I walk down the hospital hallways with the open doors and people coughing away. All right, number 2, where we are, the early inflammatory week. This is week number 2, steroids at the right time in the right patient at the right dose. This is after that first week, and this is in folks with oxygen saturations less than 94%. This is easy in the hospital. I had a patient today where one of the attendings and I were talking about, like, they got one reading. Do we trust it? Put them on a continuous pulse oximeter. We're going to see how they do over the next few hours, make that call. Number 2, anticoagulation. 3, pulmonary support. As mentioned, remdesivir if we're still in the first 10 days, and then immune modulation with things like tocilizumab. And all right, a couple exciting, I'm going to say 2, but mainly this first one is what has me the most excited in the late phase past long COVID section. So this is the article, Fecal Microbiota Transplantation for Sleep Disturbance in Post-Acute COVID-19 Syndrome, published in Clinical Gastroenterology and Hepatology. Between September 22, 2022, lots of 2s here, and May 22, 2023, they recruited 60 PASC patients with insomnia, defined as they have this ISI, which is the Insomnia Severity Index. I'm going to change that to PASC. It autocorrects to PAX. And they're going to either assign them to getting a fecal microbiota transplant or control. Basically, they're not, right? So you're going to have 30 get the transplant, 30 don't get the transplant. And the primary outcome is going to be impact on insomnia, right? So you're going to see clinical remission defined by this Insomnia Severity Index. Okay, going to have some secondary outcomes. We're going to look at the sleep quality index. We're going to look at an anxiety disorder scale. We're going to look at the Epworth sleepiness scale. I'm going to start incorporating that into daily life. How are you doing? You look sleepy. How are you on the Epworth sleepiness scale? They also have a multi-dimensional fatigue inventory. I like that too. But then they're going to check blood cortisol. They're going to check melatonin. They're going to do this gut microbiome analysis using metagenomic sequencing. Now, let's see, did it work? At week 12, more patients in the fecal microbial transplant, let's call it the FMT group, than control group had insomnia remission. So we had 38% had remission versus only 10%. The transplant group showed a decrease in that score, that insomnia severity score. So they either had remission or they were getting better. They did better on the Pittsburgh Sleep Quality Index. So they were having less issues. They were getting better quality sleep. They did better on their anxiety disorder, generalized anxiety disorder. This is crazy. You get a fecal transplant and you feel less anxious. You sleep better. Your blood cortisol gets better. Now, there was enrichment of certain bacteria, such as there'll be a test on this, the Gemminger formicalis. You got that? Gemiger formicollis, and depletion of microbial pathways producing the menaquinol derivatives after the transplant. Now, the gut microbiome profile resembled that of the donor in the responders, but not in the non-responders. So if you gave the transplant and you ended up seeing it really, I'm going to say, engraft, and you saw this change in the gut microbiome, those are the people that responded. You do it, you don't see a change, those are your non-responders.
What's the source of the fecal transplant? Healthy volunteers, I presume?
Yeah, it's now pretty involved. So they screen the potential donor, and lots of blood tests, questionnaires, any high risk things. They screen. Do you have any multi-drug resistant organisms in your biome, any other infections, and then those people then donate their poo. And then it sort of moved along. Like initially, right, we used to put a tube up from below and sort of spray it in. Other techniques, they put a tube from above. Now a lot of times they're actually taking the poo, they're mixing it with glycerol, they're freezing it, making actually what we call affectionately crapsules, and then you're swallowing those.
Wonderful.
But can you imagine? I mean, if it's going to cure your insomnia, your anxiety.
Sure.
Yeah. All right. Another study. Precision symptom phenotyping identifies early clinical and proteomic predictors of distinctive COVID-19 sequelae, published in JID. And this is always this thing. So you're trying to make the diagnosis. Does this person have long COVID? Do they have PASC? And then sort of the next step is okay. And then trying to sort of, group them. What type of PASC do you have? Because maybe that's going to help us. So here they're going to identify 3 symptom-based clusters, a sensory cluster, a fatigue, difficulty thinking cluster, and a difficulty breathing, exercise intolerance cluster. So cluster 1, this is the sensory, characterized by a higher frequency of sensory symptoms such as a loss of smell or taste. Cluster 2, this is fatigue, difficulty thinking, characterized by a higher frequency of fatigue, including mental and physical. I want to point that out, mental and physical fatigue, that difficulty thinking, the brain fog. And then you have cluster 3, difficulty breathing, exercise intolerance. Here you have a higher frequency of the difficult breathing symptoms, the shortness of breath, the exercise intolerance, the difficulty exercising. So it's sort of helpful for our clinicians to start thinking about this. But I will point out other studies have shown that over time, people can shift from one phenotype to another. So, all right, I will close as we have for a while. No one is safe until everyone is safe. We're nearing the end of June. I do want everyone to pause the recording right here. Go to parasiteswithoutborders.com and click donate. Even a small amount helps us keep doing our work. And we are doing our Floating Doctors fundraiser for May, June, and July. We will double your donations up to a potential maximum donation of $20,000. And we're going slow. We need you to step up. So everyone who's done so far, thank you. But the rest of you, come on, click on that donate button.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Michelle writes, my mother-in-law passed away about 1.5 years ago. At the time, she had a staph infection that had spread to her blood, and though she was being treated for it, it was implicated in her death. After she passed, my husband had packed up several of her items and furniture when he cleared out her room. He was gloved and masked at the time, as I am immunosuppressed, and we didn't want to have me get staph from handling her items. These items have been in our garage for about 17 months now, and my husband wants to bring them in the house. I've read that staph can last on surfaces and objects or furniture for months. Is it safe to bring these back after 17 months? These are items she had in her room while she was sick. Will the staph still be infectious? I can have him wipe down some of the items with disinfectant wipes, but not all, as several are paper products such as photos and documents as well as clothing. So disinfecting is not an option for everything.
Yeah, Michelle, it's a good question, and it raises sort of an important issue. Now, there are certain pathogens that I'll say are rare, and and when this happens, like in the hospital and other environments, we really do this big push to put precautions in place. Other pathogens are really just ubiquitous in the environment, right? Staph is notorious. We have our MRSA staph. We have our MSSA, which is a methicillin-sensitive Staph aureus. A large number of people have Staph aureus living in the nares. living on other parts of the body. People have staph living in their gut tract. Staph is all over the place. Now, the first thing I was looking at is you say mother-in-law, right? People always, when they get a family history and they want to find out what we're susceptible for, like, oh, does cancer run in your family? Does heart disease run in your family? Interesting. If you have a family member that dies of a specific infection, your risk of dying of that specific infection is much more significant than like the transmission of heart disease or cancer. Just sort of interesting little factoid that people are not aware of. So if you said, hey, my mom died, you start sort of building a different story. But no, I think at this point, I'm sort of recommendation, nothing special that really needs to happen here. Certainly, if it's been in the garage for 17 months, have your husband, clean everything up. But I don't think there's any undue risk here.
Ella writes, my niece, who is 33 weeks pregnant, has a positive COVID test with mild symptoms. Her doctor said not to worry, consider it just as a flu. Is this a valid statement, and what would be your advice?
Yeah, Ella, we've covered this a bit, so happy to hit it again. So, this doctor is certainly not following the guidance of the professional societies. During pregnancy, though the risk is low to begin with, there's about a 20-fold risk that a pregnant individual end up hospitalized, right? So we see this happen. And it's not during those first 7 days, right? It's not based on, oh, my symptoms were mild. It's what happens as far as the immune response during the second week. We also see an increased risk of miscarriage, other things. So yeah, flu is not what COVID is during pregnancy. So the general recommendation is that the benefit of early treatment with Paxlovid during that first week is better than just ignoring it and letting things progress till things end up too late.
Alina writes, I've depended on you for reliable information since the start of this pandemic. I've been glad that I did. I felt reassured by your support of mRNA vaccines. I've now had 7 of them. 1 AstraZeneca first, the others all Moderna or Pfizer, and was preparing to have the latest update this coming autumn. The attached research article, however, now makes me worried about all this. Is reliable data emerging that vaccines are riskier than was thought? I hope you will discuss and comment on the article. Should I and others like me be worried? I'll turn 70 this year, generally healthy and fit. Please comment on the study. So this is a link to a paper in Biomedicines called Spikeopathy. COVID-19 spike protein is pathogenic from both virus and vaccine mRNA.
Yeah. So let's set the record straight, Alina. We talked a little bit about our concerns that, with the mRNA platform, really critical that you keep getting vaccines every fall. There's certainly a lot of people out there that would rather you get COVID and send them your millions of dollars each month to either pay for their Substack or buy their herbal remedies instead. But no, the science is very clear. 60, 70% reduction in progressing and having issues. You say, I'll turn 70 this year. Yeah, you're one of the people. These are the people we're seeing. They forgo that vaccination either because they feel like, they've got vaccine fatigue, or some of these anti-science charlatans are trying to misinform and get you to send your money to them instead of staying healthy. And they didn't take an oath like some of us did. So, ignore this study, ignore this bit of misinformation and misguidance. There's no spikeopathy that you need to worry about.
And Lisa writes, I'm traveling to France in mid-September. Could you comment on receiving flu and COVID vaccination in late August? I know that the updated COVID and flu vaccines for fall 2024 most likely won't be available.
Yeah, we're hearing murmurs that they might be by late August, actually. Even Novavax was saying, hey, by August, we're going to have the shots ready for you. So I expect them to be ready by late August. And if so, yeah, this might be a time for you to go ahead and get that COVID, get that flu vaccine. The interesting thing we're still waiting is sort of the durability, right? So you get it in August, 4 months go by, right? So September, October, November, December. We still were seeing that the durability was still there at 4 and 5 months. So it may have been a variant issue in the past. We're not sure. But no, I think that the current guidance for you would be to go ahead with that vaccination, flu and COVID.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone be safe.